exhibit hall where I am joined by Dr. Rupa Wong of Honolulu Eye Clinic. It's great to have you here.
Thanks so much for having me. It's great to be here.
Well, I follow you a lot on social media. Also, I'll be asking you lots of questions about that later. But one of the first questions, and I think something so interesting about you and your practice, is that you are a pediatric and strabismus specialist, and your husband is a cornea specialist and refractive cataract surgeon. Can you tell us a little bit about how you opened up your practice together in Honolulu, and also what led you to hire an optometrist?
So quite honestly, we had no other choice other than to open a practice together. We moved out in 2008. I gave up a faculty position at Boston Children's Hospital. My husband had just finished his fellowship. And Hawaii is a little bit kind of like the rest of the country was maybe 50 years ago, where it's a lot of solo independent practitioners. Nobody was hiring. Nobody needed a pediatric ophthalmologist. Nobody needed a cornea specialist. So if we wanted to be able to continue practicing, we had to open a practice together because at least we could share costs. What we did was we purchased a practice from a retiring ophthalmologist, and he actually already had, as an employee, an optometrist who was fantastic. So we inherited our wonderful director of contact lens services. And initially, just because we were cutting costs, we had her on as part-time and shared her with another ophthalmologist. But within about 2 years, we were able to beef up the patient revenue and get enough patients in our door so we could get her back full time. And she's been with us for 15 years since.
Wow, that's an amazing story. So inspirational. And I love how you just kind of shared that things are just so different there. It's very different than other parts of the US where things are, you can kind of just show up and get a job. So you were kind of forced into this situation, which sounded like it ended up being a blessing in disguise.
Absolutely. It was not something I personally would have chosen. Originally, I was on a very academic track in an employed academic hospital setting, but it was the best thing for us because it allowed us so much flexibility and autonomy and the ability to create the type of culture we wanted and care for patients in the way that we want. And so it's been ideal.
That's amazing. And obviously, with your love and passion for pediatrics, myopia is something that you see daily, probably a million times a day. So what kind of brought you into myopia management, and how long have you been offering treatment for myopic patients?
Well, two things brought me into the realm of myopia management. First, my husband. If you couldn't tell, I don't look like a Wong. My husband is fourth, fifth generation Chinese living here in Hawaii. So he has a lot of high myopia in his family, personally, a lot of retinal detachments. So once we started having kids, we have 3 children. This was on my radar as to something that I did not want for my children. He has a lot of wonderful qualities, but his high axial length and his refractive error, that's not something I wanted for them. In addition, we're in Hawaii, which is really partway to Asia. And so a lot of my patients are of Asian ethnicity. We know that they are faster progressors. And I was really paying attention to the research coming out of Asia on myopia management because they've been the pioneers in this realm. So those two kind of came together, and I started offering myopia management to my patients back in 2014. I was the first in the state to do so. I started trying to educate, giving talks to both optometrists and ophthalmologists as to the research and why we should all adopt these strategies.
That is incredible. I know a lot of ophthalmologists are kind of on the fence, whereas more optometrists are really proactive with myopia management. So you are truly a leader in this space, and that's very, very exciting to have you in this field.
It's been great. I did certainly get much more pushback from the ophthalmologists and even within my own field, but I'm glad after about 10 or so years, they're starting to turn around on that.
Well, good. We'll be having this conversation again in a few years, and hopefully we'll have the same interview, and then you can tell me how things have changed over the course of a few years.
Absolutely.
So I understand that you use something called the LensStar myopia to track axial growth and refractive change. Can you kind of explain what that is and how you are using this device and software in your own practice?
It's been really wonderful because what this does is it measures the axial length of the eye. So it measures from the front to the back of the eye. And that's what we're truly concerned about in our pediatric patients. We're worried about that elongation of the eyeball, that axial elongation. That's really what we want to prevent. I tell my parents of my patients, I don't really care how thick the glasses are, but what I care really about is halting that progression. And so having the ability to use the technology that's offered by the LensStar has been fabulous because it really charts things and it allows me to educate the parents in a much more robust fashion than I could otherwise before I had used this machine.
And speaking of how you're using it, is it important to establish baselines for refraction and axial length? How important is that?
I think it's really important. Just like any kind of treatment that we do, we need to see if it's effective because some people might not respond to low dose atropine. Some people might not respond to the contact lens. So if you don't have a baseline measurement, how do you know if the treatment is working? So I do baseline measurements of axial length and refractions for every single patient. And then I repeat them every 6 months because I need to know if the treatment is working. Is it slowing the progression of the axial elongation? And again, it prints out these wonderful charts so you can see these graphs of treatment versus untreated eye. What would be the predicted growth of the child's eye if we were not doing anything? And that's so helpful at getting the parents on board because, eye drops can be hard, contact lenses can be hard, but when they see, look at the difference this is making, that's a game changer.
Yeah, and I think that just having that piece to educate parents on is so important because a lot of times there's treatments that are in place and you just kind of keep doing it because the doctor says so, right? But if we have something where we can show the parents why either we need to switch modalities or go into something else, or if we need to make a change, we can actually show them the data. Or like you said, if it's working really well, we can show them, and that kind of fosters the confidence to keep going. So that's an amazing tip. And I love that you're doing that in your practice.
Yes, it's been really helpful. And I give these printouts to the patients. We scan them into the chart and they go home with it so they can really pour over it. They love it.
That is wonderful. And I know as eye care professionals, we're always hearing the terms refractive myopia and axial myopia. Can you kind of explain the differences there?
So refractive myopia is more with regards to the cornea and the curvature and how that's focusing the light in front of the retina. Axial myopia has to do with how long the eyeball is. If the eyeball is too long, and then the light is then getting focused in front of the retina because of that, not so much because the cornea is really, really curved. And as parents, as eye care providers, we are concerned about the axial myopia because that's what these treatment strategies can halt progression. As of yet, most of the myopia is not typically refractive myopia or corneal in nature. So that's why we're focusing our efforts here on the axial. And that's also what leads to the eye health complications of myopia, retinal detachments, myopic maculopathy, cataracts, glaucoma. All those things are a result of axial myopia, not refractive myopia.
Yeah, and I love that you've kind of explained some of the complications that can arise from high myopia. And there's so many parents that when you explain, your child is going to have X amount times more chance of developing a retinal detachment if they get into this -6, -7, -8 type of category, they really kind of perk up and they're like, oh my gosh, well, if there is something that I can do about that, then I really want to look into that for my child.
Absolutely. And I think the key really is educating the parents because initially a lot of them have had LASIK. So they feel like their myopia is cured. And obviously it's not cured. Their eyeball is still long. So it starts with those initial conversations as to exactly what you mentioned. What is axial myopia? Why is that problematic for anybody? Why does that increase the risk of all of these sight-threatening conditions? And once you've explained that, then it makes a lot more sense why we want to prevent that from happening as opposed to just treating it 15 or 20 years down the road with refractive surgery.
Yes. And with the LensStar myopia software, is the printout that you get, is it easy for parents to understand, or are you having to do something with that data in order to manipulate it so that it's easier for parents to read?
Quite honestly, my technicians just print it out as soon as they do the measurement on the child. It's very easy to understand. It has curves, and I liken it to the growth curves, which most parents are used to seeing when they go to the pediatrician. They get the height curve, they get the weight curve, and I say, here's the axial length curve. And this is what's really important. It also does graph the refractive error in addition. So we look at both of those curves, and they have nomograms, so they can say, well, this would be the prediction if you are on low dose atropine. This would be the prediction if you don't do any treatment. This would be the prediction on a contact lens or on orthokeratology. So you have all of these different graphs, and it helps parents just feel more confident about making a decision that's right for their children. I mean, that's all anybody really wants. Speaking as a parent, you just want to be able to do right for your kids. And this really empowers them to feel confident that they are making good decisions. So I give everything to them. It's got, summaries as to outdoor time. I try to, emphasize that as well. Everything doesn't have to be some type of treatment intervention. Some things are very easy. They can just institute at home, like near vision work reduction or outdoor time. So all of that is also included in the printout. So I just give everything to the parents, and including a little folder that I've made up for them with some of the literature and just summarizing all the different treatment strategies. Because I just think baseline education should be just the norm.
Yeah, it sounds like you found a way to really educate the parents in a way that they can understand and make a lot of really useful tips and tricks for them that they can do at home on top of their myopia management program. Is there something that you are doing where you look at something and you say, okay, this is not working, we need to change, or we need to try a different therapy or do a dual therapy? Is there some sort of standard that you're looking for, or is it totally variable between patients?
To be honest, I do take a very patient-centered approach, and because I'm looking at their individual risk factors, and though there are certain standards that are published in the literature as to what we're looking for, I still look at ethnicity, how much time they're spending outdoors, how much time are they spending up close, their family history, and I'm weighing all of those into the threshold that I have for progression of their myopia. Much like a glaucoma patient, everybody has a slightly different target pressure, 15 for one person, a 12 millimeters for another. So I kind of take a very individualized approach to patients. Though I am following a generalized protocol, I will still have different approaches given the family history. If I know this child is outdoors playing soccer 5 hours a day and has no one in their family that has a retinal detachment, I'm not going to necessarily be as aggressive at trying to slow the myopia. I want that to happen, but I might not offer combination treatment as I would for someone who's got every single family member's got a retinal detachment. They are studying right now for school. They're barely outdoors. So those are the things that I take into account.
Yeah, and I think that what I see practitioners asking about a lot is, how do I know if it's not working or if we need to be more aggressive? And I think that we are very early on in the research for all these different modalities, and we're going to have so much more information in the upcoming years. But that's what I see as far as what eye care professionals sometimes struggle with is, okay, well, should I just increase the dose of atropine or the strength, or should I incorporate orthokeratology? Or if they're in Ortho K, how do I know when it's time to add atropine, if there is any time? So I think that's where a lot of doctors kind of get hung up is, oh my gosh, when do I know if it's being effective, and when do I need to maybe think about changing?
No, exactly. And I think especially I was just at our pediatric ophthalmology conference, and this is a topic of much discussion. Are they a non-responder to low dose atropine? So is it worth anything to increase the strength, right? These are the questions that are currently being investigated. What is the ideal percentage? Do I add on a soft contact lens, dual vision, right? Daily disposable lens like a MiSight, or do we do a orthokeratology? So those are the things that are under investigation right now. And there are studies that are coming out, posters that are coming out, publications that are coming out. So I do offer combination treatment in my own practice because we do tend to have a lot of fast progressors and a lot of parents were extremely motivated to quench, to really halt that as much as possible.
That's wonderful. And it sounds like you're very passionate about myopia management. What would you say is the most rewarding aspect of myopia management?
I'll have to say, when I see that stabilization, when we've taken a kid who was a minus 5.00 and really would have been a -7 or a -8, and I'm looking at them 5-6 years into treatment, because now we have those kids that are off to college and they literally held steady at a -5.5 over a 6-year duration. It's amazing. That would not have happened without instituting these treatment strategies really early on, even in some of my own family members that I've seen this. So that's really rewarding, because that's a huge difference, right, in their risk profile for vision threatening consequences down the road. And so we've really changed the nature of their vision and of their lives.
Yeah, that's so powerful, because we know that it would have never been that way if you hadn't intervened, right? So just knowing that you have changed that child and now adult's life, forever, and reduce the risk of some of these really terrible things that can happen, or, allowed them the opportunity to get LASIK later in life if they wanted to, where they may not have if they got to be like a -12 or something. I mean, some of that has to be really, really powerful for you.
It absolutely is. I mean, and that's also why I'm in pediatric ophthalmology, just as a field in general. Adult strabismus is wonderful too, but both are so rewarding in their own way. But peds ophtho, because we can institute changes which may seem really small. They're not super sexy. I'm not using lasers or any of that stuff, but we are really creating profound effects and profound change.
That's so great. And I know I was going to ask you about social media, because I follow you. I love all your posts. How did you even get involved with that? And how did it really explode over the last few years?
So it's really interesting. I'm just hit my 5-year anniversary of having a social media presence, a public presence. And it came to me because I was scrolling on Instagram and I saw some celebrity influencer touting some nonsense about a topic that they were not educated to really be discussing. And I thought, well, okay, there's some healthcare people on there. I see some students, I see some residents, graduate students, all of that. But if the people that are, later on in their careers, like I was 42, I think, when I started on social media, if we're not on there educating and disseminating accurate healthcare information, then what people will listen to is the celebrity influencer. So we have to do our part and get on these platforms, even if it feels a little uncomfortable in the beginning, which it totally did. I was over 40. Everybody else was at least 20 years younger than I was. And I worried about what kind of reaction I would get from my colleagues, professionally, in my community. So there was those obstacles that I had to overcome, but it's been really just truly nothing short of amazing to be able to reach people in different spheres of life across the world in this way. So I'm I'm just really excited about that potential impact, but it was a process, that's for sure.
Yes, it's not an overnight thing. I've just noticed that, some of the people that have these very large audiences, it's not something that just happens over one night. It's like you have to constantly be posting and educating and putting out content that people enjoy watching and listening to. And it's great that I love the fact that you got into it because you saw something happen and it's like, oh no, everybody's going to believe this because it's just some person that's famous. And that is really the world we live in, where people just kind of believe whatever they see and they don't research it. And, they don't have the knowledge to really know if that is a fact or not. So I think that's wonderful that you're doing that to educate and just make sure that the right information is getting out there. And you've done a wonderful job building your social media presence.
Thank you so much. It's been really fun. I mean, and I love learning new things, and it's really learning just a totally different way of teaching and talking and educating than what we would do in normal conferences or presentations. but that challenge makes it interesting. And it's been fun to be able to incorporate my kids in it. And my daughter loves doing it as well.
Oh, of course. Yeah. The kids, it seems like all of them want to be like social media influencers. It seems like. Well, I'll have one last question for you. Where do you see myopia management in 5 to 10 years?
Really see it just becoming the way that we educate parents as a baseline. I think that it's something that all parents will eventually know about, 10 years from now, that these are treatment options that are available and that there are things that can be done. I see that happening because it's slowly taking over and it's slowly just getting out there, and people are coming to me with these questions already. Slightly knowledgeable about, oh, should I do this thing, the overnight contact lens, or should I do the eye drop, or should I do, and then we can make that decision together. So I think more and more parents are going to become educated about these treatment options, which I always think is the best. The more education, the better, the more awareness, the better. And that way that everybody can collectively make decisions that are absolutely best for their children.
I love that. I totally think that awareness is key and getting that message out there. There's so many parents still that have no clue what myopia management is. They have no clue about any of these things. And I think that's going to change, in the next few years as more people become aware, more kids are in these different treatment programs and they tell their friends, and those parents are talking to those parents. And I think it will end up getting to be more of the standard of care like it is in other countries.
I agree. I think it's interesting. I did a poster and we found that 49% of parents were not even told about myopia management. So we have some ways to go. And I love seeing, and I never tell my children when I see any of their classmates, they all know about HIPAA, but if their little friends come up to them and say, oh, I'm doing that stuff you're doing, then it's very cute to see them connect in that way. And they talk about it. And then my daughter does these little eye tests in the classroom. She tries to check everybody's vision. So.
Oh my gosh, how cute. Two eye doctors in the making right there.
Yes.
Well, Dr. Wong, it was amazing chatting with you. Thank you for educating us. Thank you so much for all you do for eye care. You are an inspiration and a true leader in this industry. And it was such a pleasure to chat with you today.
Thank you so much for having me. I love talking about this topic, as you can tell, and just thank you for allowing me the chance.
Thanks, everyone. See you back for the next exhibit hall session. Bye.